Hello, my name is Chad Reyes from MedStar Washington Hospital Center. This is CVI 2017, and we are on the first day, busy day, a lot of things happening today. With me is Dr. Truong. He is staff at the Southern Arizona VA Healthcare System. Welcome, Dr. Truong.
Thank you very much.
You're going to present to us a case about uncommon path to the CTO. Go ahead.
Thank you very much. So I'll be presenting a case of uncommon path to the chronic total occlusion. Dr. Kapil Lotan helped me with this case. I have no relevant disclosure. So this is a 63-year-old man with known coronary artery disease. He was admitted for unstable angina. His echo shows an EF of 30%, and there's no significant valvular disease. In 2012, he had stenting of the circumflex and PDA at the outside hospital. And 3 years after that, he had 3-vessel coronary bypass surgery with the Lima to LAD, SVG, which was a sequential to the OM and the PDA. His other medical history, he has diabetes, uncontrolled hypertension, dyslipidemia, and he has peripheral artery disease with stenting of both the common and external iliac arteries. So here is his angiogram. You can see that he has high-grade circumflex OM disease, including the segment of the SVG to OM anastomosis. The LAD is diffuse disease and is CTO at the mid-segment. Here you can see that the circ-OM system provided flow to the RCA via the sequential portion of the SVG. The right coronary artery is occluded at the ostium. Here's the Lima graft. You see that there is subtotal occlusion lesion right after anastomosis, and the distal LADs is diffusely diseased. There's some retrograde flow into the proximal LAD, as you can see there. So here's his vein graft. The aorta osteo portion is occluded, but remember the sequential portion is patent. So in summary, he had diffuse disease LAD with a failed Lima to LAD graft. He had total occlusion of the aortic portion of the SVG, but patent sequential limb. He had high-grade stenosis of the circ-OM system, which also supplied the distal RCA via the sequential portion of the SVG, and chronic total occlusion of the RCA. His EF is low, so we had a heart team discussion about revascularization strategy, and he was not a candidate for redo bypass due to severely diffused LAD disease, and he had one failed attempt before. So the first approach was to do an Impella-supported PCI of the circ system, because this is the single remaining graft that he had. So we had Impella here and 2 wires. And after we placed 3 drug-eluting stents, we see that we had good flow to the circ. We also put 2 stents into the diag, as you can see there. So his ejection fraction improved after this, but he continued to have class 3 angina, so the decision was made to revascularize the RCA. So you saw the first shot there, that was an LAO, and here's the REO shot. You can see the flow to the RCA is from the circ system. So we started with an antegrade approach, which was not successful. We tried with wire escalation from the Fielder XT to a Pilot 200. So the choices now was to either do dissection reentry or do a retrograde approach. Now, since we have a very good conduit from the circ system into the right system, we decided to do that. So we have a guy in the left main, and then we were able to wire through the circ, through the stent, into the sequential portion of the vein graft, into the PDA, into the RCA. And here are the results after we placed 3 drug-eluting stents into the RCA, covering the ostium, with good outflow to the PLB. So in conclusion, aortic coronary SVGs are often used as a conduit for retrograde approach in CTO PCI. In patients who had a sequential vein graft, the coronary to coronary portion can serve as a good pathway for retrograde crossing. And in this case, it was actually much easier to cross than the usual septal collaterals we cross from the LAD to the RCA. Thank you.
Great case. Thank you everybody for watching. Thanks for presenting the case. The highlight of this case is the RCA water escalation and then to use the other side conduits as early decision making. Great case. Thank you for presenting. This is Shadi Reyes and this is CVI YouTube channel, and follow the Twitter account CV Innovation and the hashtag CVI2017.